Today's presenter, and the reason why everyone is on the phone and watching, is Dr. Christine George. Her educational information is up there from George Washington University School of Medicine and Health Sciences. This is her final year in the PEDS residency here at Carilion Children's. She is going to be relocating to the Boston area in July and is looking to pursue some work as a PEDS hospitalist. With that, I'm going to go ahead and turn it over to her. Thank you very much for joining us.
All right, good afternoon, everyone. Okay. Today we're going to be talking about a 16-year-old boy with new onset seizures and electrolyte abnormalities, and I have no disclosures. All right, so for our history of present illness, this is a 16-year-old boy with severe autism who presented to our emergency department by EMS after experiencing what was described as a seizure-like episode while at his pediatrician's office. Now, of note, the history was definitely limited. The patient had minimal ability to communicate verbally at baseline due to his severe autism. So to set the stage, he was at his primary care provider's because of 1 week of progressively worsening fatigue, malaise, some abdominal discomfort, and decreased appetite. He had a fever the day before, but didn't have any on the day of presentation. Decreased amount of urine output, and parents noted some dry heaving, but no actual vomiting. There was no diarrhea or constipation, no runny nose or nasal congestion, no cough, no shortness of breath. And also had no recent travels and no known sick contacts. To further describe this seizure-like episode that he had, so it was witnessed by his mom while they were waiting to get some blood work at his pediatrician's office. And it was described as just sudden loss of tone, followed by about a 5-second period where he had facial and bilateral arm shaking. But unclear whether or not he actually lost consciousness, and he just seemed really tired and even more weak afterward. Also, as part of that, there was denied any loss of bowel or bladder control. Parents denied any known history of trauma. He doesn't take any medications at home, and there was no known illicit drug use or prior history of seizure, and parents denied any known family history of epilepsy. So to complete the history, so he was a triplet born at 36 weeks by a C-section. Only other condition other than his autism is he had some ADHD. Just wart removal for prior surgeries, no allergies, no medications. His paternal grandmother had a history of a thyroid problem, but parents were not able to provide more specifics. And the paternal grandfather has a history of prostate cancer. Otherwise, he lives at home with his mom, dad, siblings. They have a pet dog, city water, nobody smokes. So our physical exam, this is when he arrived in the emergency department. Things that are highlighted in red are highlighted as those that are abnormal. Obviously, his blood pressure was a little low at 85/60. He was a little tachycardic at 116 beats per minute. Normal temperature and respiration rate, and he was saturating well on room air. Additional parts of his exam, he was very thin and seemed to be mildly ill-appearing. Also had very dry mucosa, but his neck was supple and had full range of motions. His pupils were equal round reactive. Again, as I said, he had some sinus tachycardia, but we're not able to appreciate any murmurs, rubs, or gallops. His respiratory, abdominal exam, GU exam were completely normal. Extremities, there was no edema or deformities. He had strong pulses. Capillary refill was slightly delayed at about 3 to 4 seconds. His neurologic exam, unfortunately, was limited a lot just due to his baseline developmental delays and somewhat not always cooperating with parts of the exam. he was sleepy, but he did wake up appropriately and just really had just generalized weakness, but there were no focal deficits or other movement disorder abnormalities noted. He responded to some commands, but he doesn't really answer questions, and he will just repeat an exact word that was just spoken to him. And parents say that aspect of it was actually normal for him. On his skin, there was some hyperpigmentation that was noted on his hands, feet, and face, and he just seemed to be a lot darker compared to his parents who were standing at the bedside, but there were no other rashes or lesions. So now kind of just taking a step back and trying to think about broad differential diagnoses. Obviously with that low blood pressure, shock is in your differential, and he had evidence of possibly some dehydration, so hypovolemic shock. He had this history of a fever the day before, and sepsis can present in many, many different forms, so are we dealing with some sort of infectious etiology? Is this adrenal cortical insufficiency? And this episode, did this represent a new onset seizure, or was this more of a syncopal episode? So to start off with, kind of attaining just some basic labs to get a better picture, including a CBC, a comprehensive metabolic panel, urinalysis, urine and blood cultures, and also an EKG. And then go ahead and starting IV fluid resuscitation, given his obvious evidence of dehydration on exam with the low blood pressure. So while those while those labs are in process and he's getting some fluids, you're able to get some additional information from his parents and do a more comprehensive review of systems. And you realize that he had about 5 to 6 months, over the last 5 to 6 months, he's lost weight. And that's been noticed by his pediatrician, over about 15 pounds inadvertently in the last 6 months. And also this hyperpigmentation that you commented on, they said that's also new, and that he looks tan even though he has not been out in the sun, and that he's just noticeably darker than his siblings as well. So now going on to our lab results, which have resulted, and here's just a reference frame for you. We're about to fill in the actual lab results. Okay, so we see we have a normal white blood cell count, normal platelets, and normal differential, but our hematocrit and hemoglobin are a little bit elevated. Sodium is low at 123, and potassium is a little high at 6.1. Chloride low at 86, bicarb is 19, and azotemia with the BUN of 79 and a creatinine of 2.96 and normal glucose. Liver enzymes are normal. So just to kind of summarize it in writing here for you, it looks like, again, some hemoconcentration, hypernatremia, hyperkalemia, hypochloremia, metabolic acidosis, prerenal azotemia, and evidence of an acute kidney injury with that elevated creatinine. So to summarize everything that we've talked about thus far, 16-year-old with autism, he had this brief seizure-like episode in the setting of 1 week of fatigue, malaise, and decreased intake and abdominal pain. And he's also had several months of unintentional weight loss and skin color changes. Physical exam was significant for thin appearance and hyperpigmentation, as well as signs of dehydration. And the labs are exactly as I had just said, with low sodium, low chloride, but high potassium, acidotic, and evidence of acute renal injury. Our next step is to consult endocrinology. Because now our primary concern is adrenal insufficiency. So to talk a little bit about adrenal insufficiency, deals with impaired production of glucocorticoids and mineralocorticoids that are normally synthesized in the cortex, and that's caused by different defects anywhere along the hypothalamic pituitary adrenal axis. So to show this, you have the hypothalamus, which will produce CRH and then to signal the anterior pituitary, which then pushes out ACTH and stimulates the adrenal cortex to produce its two primary hormones, which are cortisol and aldosterone. It also does produce some sex hormones as well, but overall it's a small part of what it does. The aldosterone goes into that renin-angiotensin-aldosterone system, and the cortisol causes some negatively inhibits further production of the hormones from the hypothalamus and the anterior pituitary. When you're dealing with primary adrenal insufficiency, basically there's a problem within the adrenal glands. Secondary, there's a problem with the anterior pituitary, and tertiary, there's a problem with the hypothalamus. So when we're talking about adrenal crisis, that's the emergency that ends up resulting as a result of an acute relative insufficiency of adrenal hormones. And those can often be in the setting of some sort of illness or other physiologic stress states. So next steps in management and workup, just generally thinking about this, is that we're suspecting that he has some acute adrenal insufficiency. In the case with very severe symptoms and when they're unstable, of course, start appropriate fluid resuscitation, depending on whether or not they're hypoglycemic, is whether or not you would have dextrose in your resuscitation fluids. But for children, we're talking 20 mLs per kg of bolus, and you can do up to 3 of those in an hour. Then you'll obtain baseline cortisol and ACTH levels. This is serum. Then immediately you give IV hydrocortisone. That can also, if you don't have IV access, it can be given IM as well. And that's going to be given at appropriate stress doses. Again, I just want to highlight again, no matter what, you really need to obtain baseline cortisol and ACTH levels before giving any steroids. And that is just, again, quick blood draw, save it, put it to the side, because we will not be able to go back and get a good idea of the patient's cortisol levels after hydrocortisone is artificially given to them. Once they've been stabilized, you can temporarily kind of wean them off the steroids, and then you can do your, we call your standard dose ACTH stimulation test, which we'll talk about more in a little bit. For mild to moderate symptoms, similar, but basically you're saying that, okay, you have about an hour of additional time that you can take to perform a test to have more definitive results. Again, fluid resuscitation, and then instead of immediately jumping on obtaining the, thinking about giving steroids, you'll actually go ahead and do the standard dose ACTH stimulation test. Again, we'll talk about that more in a minute. In addition, at that time, again, drawing blood, it can also be very helpful to get plasma renin and aldosterone levels. And that's really to look and to see if there's evidence of a mineralocorticoid deficiency in addition to a glucocorticoid deficiency, and which only occurs in primary adrenal insufficiency. And that would be seen with a high renin and low aldosterone levels. After the stimulation test is done, then you would give the hydrocortisone IV, or if you need to, IM, intramuscular. So just a quick review of the ACTH or Corticotropin stimulation test. So this is really the gold standard to diagnose primary adrenal insufficiency. And dose depends on your age, and the for an almost adult, like the 16-year-old, we go for 250 micrograms of Corticotropin, which is a synthetic kind of version of ACTH. So, but prior to administering the synthetic hormone, you will obtain your baseline cortisol and ACTH levels, just as you would if you were not doing the test. And then you obtain additional levels of both of these hormones at 30 minutes and then at 60 minutes after you've administered the synthetic hormone. And really what you're looking for is that if your cortisol continues to be low despite giving a proper stimulus with the ACTH, and which again you will see you should have a high ACTH to begin with, and it will continue to then be high with this test that indicates a primary adrenal insufficiency, or something's basically not right with the adrenal gland itself. So going back to our case, his cortisol baseline before administration of any medications was 5.98 micrograms per deciliter, and as you can see that it did not change much at all. It actually even went down a little bit with time after being given the Corticotropin. His plasma ACTH, again, that was initially based off of his baseline, that was drawn at the same time as his baseline cortisol, was extraordinarily elevated at 3,800. And really, it would only have had to be elevated more than 2 times of the upper limit of normal for it to qualify. His was much, much higher than that. So next step, you see this, okay, definitely start the hydrocortisone. Again, IV or IM at the appropriate stress dose. And for children, we're talking 50 to 100 milligrams per meter squared bolus, and then starting on maintenance of 50 to 100 milligrams per meter squared per day, divided every 6 hours IV. Preferably, but again, if you are in a front, you're waiting for help to arrive to help get a better access, you can do that IM if you need it. So now we're going to talk a little bit more about primary adrenal insufficiency. Some of you may remember from medical school learning about the eponym of Addison's disease. So Thomas Addison in the late 17th and early 1800s, my apologies, was the first one to actually describe adrenal insufficiency in the medical literature, and that was in 1855 on his paper on the constitutional and local effects of diseases of the suprarenal capsules. And that is where he ended up doing a number of autopsies on individuals who all had this similar pathology, and he had noticed that there were issues with the adrenal glands themselves that he hypothesized was the cause of their death. So etiology in children, breaking it down into both genetic and acquired causes. The most common cause of primary adrenal insufficiency in children is congenital adrenal hypoplasia. Another cause to keep in mind is adrenoleukodystrophy, or a more mild form of that is adrenomyeloneuropathy, and that's an X-linked recessive disorder that has to do with the peroxisomes and issues with long-chain fatty acid beta oxidation. Additional ways that children end up with primary adrenal insufficiency include autoimmune adrenal insufficiency, which is the second most common cause. It's the most common cause in adults, but again, the second most common cause in children. And that can be just an isolated problem with the adrenal glands, or it can be part of a larger complex of larger syndrome, being polyglandular autoimmune syndrome type 1 or type 2. It can also be caused by infections. Tuberculosis is a known cause of this, and for those who do work internationally and in places where there is a higher prevalence of tuberculosis, this as a potential cause should be higher on your differential. Other things like disseminated fungal infections, histoplasmosis, HIV, and syphilis have also been shown to cause PAI. You can also have adrenal hemorrhage or infarctions due to meningococcemia is known to cause Waterhouse-Friderichsen syndrome, and having to do with a severe hemorrhage of and then resulting ischemia to the adrenal glands themselves. Cancer can also metastasize and cause problems with the adrenal glands, as well as certain medications can cause acquired PAI. All right, so the to just kind of have a basic overview of, okay, where do you go from here now that you're thinking a primary adrenal insufficiency? If it's an infant or, again, in select children and adults, if they have other signs and symptoms, you might consider getting a 17-hydroxyprogesterone, and that's really to determine whether or not this is congenital adrenal insufficiency. Hyperplasia, excuse me, congenital adrenal hyperplasia. Otherwise, the next test is going to be 21-hydroxy antibodies or anti-adrenal antibodies, and that's to rule out in the second most common cause, which is autoimmune adrenal insufficiency. If those end up coming back negative and it's a male, you would consider looking at very long-chain fatty acids and to determine whether or not that this child has adrenal leukodystrophy. And if that then, if you're still batting zero, the next step would be a CAT scan of the adrenal glands and to really look for, make sure you're not missing infiltrative disease, hemorrhage, infections, tumors. And then that comes back as normal. Again, then you're dealing with the category that can be often difficult, but does happen with idiopathic. We don't quite know why. So going back to the case, this child, again, he was admitted to the pediatric ICU after once this was identified and started on stress dose of IV hydrocortisone. His mental status gradually returned to baseline, and he, with fluid resuscitation and his electrolytes also normalized. And he did this quite rapidly within 24 hours. He was then transitioned over to maintenance oral hydrocortisone 3 times a day, and also started on maintenance fluorocortisone for mineralocorticoid repletement, and discharged home with his parents on hospital day 3. To follow up, since he was discharged home, we did obtain anti-adrenal antibodies, and those were negative. Also, he was tested for very long-chain fatty acid deficiencies, which were normal, looking for leukodystrophy. And on last update, parents were still weighing the risk and benefits of obtaining a CT scan. And on his maintenance steroids at home, patient has been acting more himself, and he's gained back over 7 pounds since starting on the steroid replacement therapy. So to summarize just some key teaching points, signs, symptoms of adrenal insufficiency are very vague and can be very difficult to highlight, to recognize in the heat of the moment. But anytime you have somebody with very vague symptoms and they look pretty sick, and you see something like hyponatremia, hyperkalemia, and hypoglycemia, adrenal insufficiency should be high in your differential. In addition, hyperpigmentation is also present when you're dealing with primary adrenal insufficiency. You diagnose this primary adrenal insufficiency with the Corticotropin stimulation test, and that within that the cortisol stays low, but the ACTH is high. But remember, before giving any hydrocortisone, to please collect cortisol and ACTH as a baseline. Most common causes of primary AI in children are congenital adrenal hyperplasia and autoimmune adrenalitis. And you, again, treat the crisis with IV hydrocortisone at stress dose along with IV fluids. Once stable, you'll transition them to oral therapy, oral hydrocortisone for glucocorticoid replacement and flucortisone for mineralocorticoid replacement if needed. And now I'm going to open it up to for questions to the group. Just so everybody knows, I do have Dr. Reynolds here with me, one of our pediatric endocrinologists, if there are additional questions that I'm unable to answer.
Perfect. Thank you very much, Dr. George. All right, so I'm going to go ahead and open up the phone lines. Now, I know that's a lot of information to convey in 25 minutes, so I applaud you for getting through it in a very nice manner. All right, so I'm going to unmute the phones. We've got about a minute and a half left, so if anyone has a question, you can ask it in just a second. Do ask that if you do not have a question or you do not want to make a comment, just put your phone on mute so that we don't hear your background noise.
The conference is now in talk mode.
Hey, does anyone on the line have a question for Dr. George or also need to do an endocrinology consult here with Dr. Reynolds? Going once, going twice? Okay. The one question did come in over the line. Our case specifically, the kid went to PICU. Is it typical that that is where we try to manage these kids at first? Did we do that because of his potential septic shock or hypovolemic shock? How would we approach that? Since a lot of our audience tend to be ER staff, ER physicians from the community, or places that might not have a PICU or a pediatric floor available in their system, how would you recommend they approach managing these kids? Either one of you.
I think it has to be a case-by-case decision made in conjunction with your local hospitalist and intensive care unit folks to see what's the most appropriate location for that patient. This particular patient, in addition to his electrolyte abnormalities, also had some acute renal failure, which I think made us a little bit more concerned about him as well. So, yeah.
Okay. Perfect. All right. Any other questions on the line from the group? Going once, going twice? All right. You've got some prep questions here. I threw in, let me skip over here. All right. Just a reminder, if you are listening to this live and you want your 0.5 hours of Category 1 credit, go to your calendar appointment where you logged on for this webcast and go down to the CME credit survey, fill that out. And if you're listening to this as a recording, you can go down to the notes section of the YouTube video and click on the CME link. If you ever want to see how much CME credit you have through Carilion, you can go to carillionclinic.org/CME and go to the CME tracker system. You set up your account, and everything you do through Carilion for CME gets dumped into that system, so you can go back and look at all of your activities to make sure you're up to date. And then just for future, join us for Grand Rounds. We do those on Thursday mornings at 7:30, and then we try to do our Lunch and Learns once a month where we try to focus them on case formats. I believe this year seems to be popular, so I think we're going to continue doing that. And if there are no future or further questions, we'll go ahead and disconnect the phone lines now. 1 minute over, so we were almost perfect. Any other questions? No? Okay. Thank you all very much, and we're going to disconnect the phone lines now.